board here. And I'll just, for the recording, say good morning. My name is Sydney Bell. I'm with the Ontario CAPC CPNP Provincial Network, and this is the Maternal Mental Health Community of Practice. We're meeting on Tuesday, February 26th, and we are hosting a discussion on the Registered Nurses Association of Ontario's guidelines for perinatal depression. Okay, so Janet, I'm going to hand it over to you. And you just let me know when you want me to screen share the document.
Okay, thanks, Sydney. So just to provide some background context, I am a public health nurse. People on the call know this, but you won't on the recording. I work for Halton Region. I am a CPNP facilitator in Burlington, and I also am a reproductive health team. I'm the lead for perinatal mental health. So just a bit of background for people who aren't nurses. RNAO is the Registered Nurses Association of Ontario. It's a professional body, so it is a group that puts together best practice guidelines and webinars and seminars and things like that, primarily for nurses. So if you're running across nurses in your practice, whether it's public health nurses, nurses in the hospital, nurses in the community, they should be aware that there is a new best practice guideline around perinatal depression. I was thinking about this last night, and that doesn't necessarily mean they're following it. It just means that there are clear recommendations for practice. The actual purpose of this best practice guideline, and I'm now on page 6 of the document, is stated that it's here to prevent evidence-based recommendations for nurses and the interprofessional team across all care settings. So it's really not just limited to nurses, even though that's kind of who it was created for. And that's amazing because we all know in the community when it comes to the mental health of the mothers and mothers-to-be that we work with, that we have to do it as a group. We can't just have the doctors treating them or the the CPNP facilitator making a recommendation. We need to work together. So the idea of having evidence-based recommendations is that we want to enhance the quality of our practice to support reducing the incidence of perinatal depression. So in other words, we want to see the statistics drop. And what we know right now is that perinatal mood disorders, so that's anxiety, depression, postpartum OCD, postpartum, even postpartum psychosis, that whole group together, that affects 1 in 5 women. It's the most common complication of a baby, believe it or not. So we're looking to reduce those numbers if we can. And what this guideline suggests is that we adopt routine screening, assessment, coordinated interventions, and evaluate what we're doing. The scope of this guideline is that perinatal depression is the most commonly occurring mood disorder during pregnancy and postpartum. And it doesn't really get into too many of the statistics here, but postpartum depression is the most common of all of them, whether you look at prenatal anxiety or depression or whatever. Postpartum depression is probably the most common. And this is because we have the statistics that back that up. So moving down to types of recommendations on this page and onto page 7, what is said here is really just a repeat of what I said. It's primarily, the practice recommendations are primarily for nurses, but they're really for the whole interprofessional team. There are some education recommendations in here, and those are supposed to be for people who educate nurses and the interprofessional team. So your college instructors, your nursing managers, your managers in your CPNP programs, those are the people that the education recommendations are directed to. And then organization and system policy recommendations, that's some very high level stuff. So basically, to continue with this, it says that recommendations pertaining to screening and assessment integrate reviewed literature, but do not include a preference for one tool. So this is kind of interesting. In this best practice guideline, there is not one way to screen that is recommended. And I have to say, some of you may have heard of different ways to ask women how they're doing and talk about it. In my region, we use something called the Edinburgh Postnatal Depression Screen, or the EPDS. We'll talk about that a little later. Public Health Ontario recently came out with a perinatal mental health toolkit, and they recommend the Edinburgh, but this doesn't. So basically what it's saying is, we want you to screen, which is not a diagnosis. We want you to use a tool when you're talking to women to guide your discussion with them and the recommendations. On the next page, actually I'm up to page 9 now. There's a pretty detailed chart, and if you're really into how do we know that good research is good research, you're going to love this page. For most of us, what we need to know is that there's different levels of telling whether we can rely on the research or not. Anything that is in the 1 level is pretty reliable. Anything that is in the 2 level is also fairly good, but not as strong. And it goes down like that. So when the recommendations are listed in this guideline, in brackets behind the recommendation, there's always an indication of how strong the evidence is. So that's what those numbers mean if you're looking at it. Then there's also on page 16, I think it is. No, sorry, I need my reading glasses. It's page 10. There's quality of evidence, and really what this says is there were specific tools that were used when they looked at all the studies. So there was kind of a framework for doing that. So the summary of the actual recommendations, and this is the nuts and bolts of what's happening here, is page 11 to page 13. And different ones of us are going to sort of discuss what these mean. The first practice recommendation is around assessment. And you'll see that there's some recommendations about screening and assessment in there. The second set of recommendations is around intervention. So in other words, once we know that a woman is actually experiencing symptoms, whether in pregnancy or after the baby's birth, what the heck do we do about it? And that's the big question, because once you assess them and you figure out that there's some level of depression or anxiety, and again, this one talks more about depression, what's the next step? So that's really what the second set of recommendations are about. And it's a huge list. If you go down the list, Sydney, you'll see there's recommendation 2.1 all the way to recommendation 2.10. So you wouldn't do everything with every woman. This is more about, here's some options. These are some things you could do. And, let's take the example of a CPNP group. You're probably not going to have a chance to sit and talk to a woman about recommendation 2.8, which is support informed decision-making and advocate for access to pharmacological interventions. But it's helpful to know that that's there, because if somebody talks to you and says, I'm not feeling well, my doctor has said that I want to take medication, I don't want to take it. What you would do is say, do you know where to go to find some good information about that? That's how you would cover that recommendation. So you might refer that woman to Mother Risk, which is a great organization that does a lot of research. You might refer her back to her family doctor. So some of these you won't do, and others are just kind of one-liners in your conversation. The recommendations 3.0, so those ones, they're all to do with educating. So This is for if you're training people up in the profession, whether it's nursing or ECE or community workers or whatever, dietitians, etc. And then recommendation 4.0, that's very, very high level, so we probably won't even get to it. So we're going to jump from page 13. Actually, are there any questions about that right off the top? It's a lot of information.
Hi, let me just unmute everybody because I did a bit of a, feel free to type a question, and I'm also just unmuting everybody here. Anybody have any question for Janet? I apologize. I think I've unmuted everybody. Any comments or questions?
Okay. If there's no questions, we can just keep going because there's a lot of really great information in here. So we're going to jump ahead to page 28 and 29. And just to let you know, there's all kinds of pages in the middle here, Sydney, about who participated and who was consulted and yada yada. Good section in there about what actually is postpartum depression. I think you're scrolling past some of that.
Yeah, I'm sorry. The pages are so small, page numbers. Am I where I'm at here? 24?
So yeah. So we're going to go to 28.
28. Okay. Oh, here we go. Guiding frameworks.
Yeah. So this is kind of a background thing. When the people who put this together or putting it together, what were they thinking about? So this should all be really familiar to any of us who do CPNP. Basically, the three big frameworks they used were social determinants of mental health. So that's a bit like social determinants of health, but what it is more focused on what is going to affect mental health. So things like, housing, where you work, how much education you have, where you live, how much support you have around you, even things like public policies around mental health. So, and access to things. So does your community have, a mental health worker or a psychiatrist who really understands perinatal mental health? All of those things are going to impact the care that the women we see will get. And, interestingly, CPNP is really one of those programs in CAPC. They're designed to reach out to people who might have more needs in those areas. So that's good to know. Person-centered care just basically means there's no cookie cutter approach to this. We have to be really aware of what the women want for themselves, and we have to figure out what's going to work for them. So for some people, what they need is the encouragement to follow up with their doctor. For other people, we need to say, you know what, I think that you probably are going to be okay if you just go to some programs, like keep coming to CAPC, and let's talk about how you can build in walking in your daily routine and, get out and get some fresh air. That's really going to help your mental health. The last guiding framework is really informed decision making. And this is important with anything to do with mental health, but one of the key features of perinatal depression really is that women feel kind of powerless. They feel like they're not good mothers, that they can't do anything right. So, having a conversation in the context of, what do you want to do and do you really understand? For instance, you've just shared with me that you have some very disturbing thoughts sometimes. So are you okay if we make a call together to your doctor, to your public health nurse, to, somebody in your life, or to your partner to come and pick you up at the program and take you to your family doctor? So just making sure that we're not imposing decisions on people, I think is what that is really about. And I think at this point we switch over to Ellen, who's going to look at, am I right on this? Yes. Ellen was going to look at practice recommendations, so 2.1 to 2.5, and that's pages 32 to 65. I'm just realizing I don't actually think Megan is on the line, is she?
I do see Megan here on Zoom.
Okay.
Hi there, I've joined in.
Hey, Megan. Good to have you. Megan, back when we set this up, you were going to do practice recommendations 1, 3, and 4. Do you want to talk? Are you comfortable talking a bit about practice recommendations 1, which is pages 85 to 87?
Yeah, absolutely. I can help you out with this.
Excellent. Well, I think it makes sense for you to go, and then Ellen, for you to go to practice recommendations 2.
Okay, and we're doing that, both of those this morning?
We'll see how far we get.
Okay.
We'll see how far we get. Yeah.
Because we might need to, think of another solution for Ellen, since she's, we don't have her on a microphone. So maybe we could do that the next time.
Yeah, that's a good, I had forgotten about that. Yeah. So Megan, if you want to go ahead with recommendation number 1.
Absolutely. So we're looking at our practice recommendations at this time.
Megan, sorry to interrupt, but you can see the screen. Am I on the right page for you and everything?
Yeah, I hope I've got the numbers right as well. That's what I'm looking at.
Okay.
Perfect.
Okay. You just tell me, and you tell me where to go in the document, and I'll go there.
Sure thing. So Janet, you did a great job of summarizing all of that. I think it gave a good icebreaker as to what we're looking at right now for practice recommendations. Honestly, I thought this was really great for public health, because we're always looking for a bit more of direction with the screening. When should we be screening women? What's an appropriate time? What tools should we be using? And it really was an eye-opener. It really is very open when it comes to the recommendations. So it was nice for us to know we're in the right direction. This practice does recommend routine screening for perinatal depression, and from the research that we've conducted, formal screening really does go a long way compared to just asking a woman, how are you feeling? So this was really good to validate some of the tools and assessments that we do conduct at our health net. More and more, we're seeing the screening become a part of the prenatal visits. And so I'll just provide you with a few, I'm just going to highlight a few points. Of course, the document's so detailed, so you really have to get in there and read it for yourself if it interests you. But routine screening we're seeing is now reinforced. Having those open conversations really helps to destigmatize any mental health concerns that a mom may have. We're not so much assuming that having a new baby is a happy time and that mom is feeling well. So we really are working towards having those conversations with all levels of healthcare providers. When it comes to the screening tool, as Janet mentioned, there really is not a particular tool that's recommended. But of course, we want to use something that's evidence-based, that is reliable, and that really lists, a particular set of symptoms, especially when it comes to assessing if mom is at risk of any self-harm or of harming her baby, which the Edinburgh postnatal depression screen does help to identify the final question 10. And these screens are also listed in Appendix E as well. So you can always have a look at the Edinburgh if it interests you and if you're not familiar with it. As well, they do provide an appendix for responses to maternal suicidal ideation, which can provide a lot of guidance for someone who's not familiar with response protocols to these types of concerns. Looking over at the timing and frequency, again, there's no particular guideline. However, moving further into this document, we can see that there are a lot of examples of what types of settings may conduct screening and how often. And I know for our health unit, this is one we'll be following, is beginning the prenatal screen as early as 26 weeks gestation, and then doing a routine screen by about 8 weeks postpartum for mothers to help identify any mood changes during those times. Very important to be mindful of those first 2 to 3 weeks postpartum because we know that's a time where a mom is very likely to experience changes in her mood. And so we really want to be mindful if we are going to screen during those early days that mood is subject to a lot of change. I don't know if I'm on the right track, if anyone has any questions at this time.
Hi, Megan.
Hi.
Just want to, I don't have a question, but I just want you to know we're here and we're hearing you, and it's good. If anybody has a question, always feel free to either unmute yourself and ask, or type it into the chat.
Great, thank you.
I think you're good to go.
Great. Screening of postpartum mood disorders, or perinatal mood disorders, I should say, can be conducted by anyone of the a health team, and it can be conducted in person or by telephone. Myself having some experience by telephone, it certainly can be done. A little more challenging with screens like the Edinburgh, because it does provide you multiple choice options to assess the severity of symptoms and how mom is feeling. And so, that can also be a challenge when we are screening moms, but it's still always important to take hold of any opportunity if you do suspect a mom may be affected by mood disorders. And of course, we don't just want to screen moms, we do want to arrange some follow-up. And this may look very different depending what your place is in the interprofessional team. Sometimes it is just, as Janet mentioned, hooking a mom up with some support, a parenting group. Sometimes the scores are not alarming, are not above the cutoff score, but do identify that mom is feeling tearful and is not feeling quite like herself. So these are good options to turn to help mom regulate any changes in her mood, to help return to her everyday activities. For myself as a nurse, it's often looking at any referral and pathway opportunities to connect the mom to further mental health services. And really, regardless of the screening results, we just want to facilitate that conversation and help our moms to feel supported. So we're looking at her circles of support. Is mom receiving any partner support? What are things looking like at home that may be affecting her mood? Oftentimes as well, perhaps mom is struggling with breastfeeding in the early days. All of these factors certainly have an impact. It was very interesting to read one of the points. I think it was one of the several points here that mentioned screening can also trigger some discomfort in clients, especially clients who have a traumatic history in their life, or perhaps experience some difficulties, perhaps fear of judgment by the healthcare provider, which can also impact the conversation with healthcare providers when it comes to screening.
Megan, can I ask what page you're on, or?
Yeah, I'm still in the first set here. Let me see.
Okay, I just want to make sure I'm kind of.
Yeah, I think we're still on the right page. If you're at page 33.
Oh, okay.
Yeah, and then I'm going to be moving on to 34 very shortly.
Okay, great. Thank you.
I did just some bullet points, but I know I'm pretty close to that point there.
No worries. Thank you.
Great. So a number of factors that we can explore when it comes to building and facilitating that relationship with the healthcare provider when it comes to screening, especially mental health is such a topic that's very sensitive in nature for a lot of moms and expectant mothers. Now moving on to, I believe our page 34 very shortly. We just want to consider our screening practices that we're engaging in. And so we immediately do want to interpret any results. If we screened a mom, we want to take and ensure that we have the time to review the scores with that client, ensure proper follow-up, establish a plan, especially if mom is experiencing any thoughts of harm. We want to score very cautiously and rely on our clinical judgment. And so a mom perhaps does not have scores that are very alarming, but something's not feeling quite right. We feel that mom is lacking certain supports. It definitely is up to that clinician or healthcare provider to make the call as to what's the next step and what type of follow-up is required for that client. And being mindful as well, we know the Edinburgh is one of the screens that is translated, is available in a number of languages. So as much as possible, we want to ensure understanding from the client, gain a good understanding of their personal background, what types of supports are in place, and their readiness to be screened and identify any challenges at that time. So what are the red flags that, cued us to want to screen this mom, and having that open discussion with her as well. More screening practices are outlined on pages 35 and 37. I'm not going to go into depth too much with that. They are very, very straightforward. And so I'm just going to skim through here. So then this will bring us to our 1.2.
Megan,
Yes.
I'm wondering if I can just add a couple things, if it's okay.
Absolutely. Please jump in.
Okay. You've done a great job, by the way, of covering this.
Thank you.
I was going to say that if you haven't routinely screened people before, it can also produce a lot of anxiety in the person doing the screening. And I know this from personal experience. So it's just a suggestion. If you're starting to do the screen, if you can approach it with more confidence than you feel, that is one of the things that really places women sort of in a calmer place. So for instance, when I'm doing a screen, I may say to people, this is something I do on a regular basis, or I've done this many times, or this is something I usually do with new moms who come to the group, just to kind of let them know I'm not looking across the room and thinking, oh my goodness, you're really not well. I'm just doing this as part of my routine practice. And I think that kind of wording really helps set the tone. The other thing I wanted to mention is the actual time. So we are talking a lot about the Edinburgh. I will talk about that. It's a 10-item self-scoring screen, multiple choice questions. So the actual time for the woman to complete it is, I don't know, 5 to 8 minutes. It's not an all-day thing. And going through it with her, more times than not, you're going to have somebody who has some symptoms but does not have lots of self-harm. So, the anxiety for us sometimes is, oh my gosh, what if I screen this person and they're totally, really, really ill, and what do I do about it? If you do this on a routine basis, you're going to get lots of people who aren't really, really ill. So that's another thing to remember. And as Megan's already said, that's an opportunity to just have a great discussion with these moms about how are you taking care of yourself. So that's just what I wanted to add in.
Those are wonderful points. Absolutely.
Are you there, Megan?
Yes, I am. I was just holding for any additional questions or comments.
Sorry.
I'm ready to move on if everyone else is.
I think so.
Okay, perfect. So headed to our recommendation 1.2.
And that is on page?
I have it right here on page 41. Those numbers are small.
They are. 1.2, thank you, Megan.
Yes, and this one was conduct or facilitate access to a comprehensive perinatal depression assessment with persons who screen positive for perinatal depression. So in a nutshell, this recommendation really highlighted other considerations that you really want to keep in mind when you're screening a client. And Janet did speak to this earlier. We really want to have a look at the whole context. And so what are risk factors that this mom is experiencing that put her at risk of developing perinatal mood disorders? Is mom experiencing any somatic concerns? And especially we see this in the postpartum period where these symptoms are interfering with sleep, mom's eating, having lengthy periods of tearfulness and persistent tearfulness. Any health inequities that this client may be experiencing, perhaps they're living in poverty or struggling, financially. All of these stresses really play a part in maternal mood. Also, we want to consider those difficult factors that may affect mom's readiness for screening and supports, such as attitudes towards her pregnancy. Is mom currently perhaps dealing with some substance use or have unresolved trauma or grief are also factors. Also, it does mention mom's risk of self-harm, especially if mom has scored positively to question 10, which screens for thoughts of self-harm. Has mom had past attempts in her life, or has she struggled with mental illness? Is mom being followed up for her mental health prior to this pregnancy? Second, I believe we're moving over into our next page very shortly, page 42. I just really summarized healthcare provider attitudes towards screening and towards the mom as we really consider the whole experience for this expectant mother. And so we really want to work towards establishing a trust, helping moms to feel empowered and engaged. And a lot of this, as Janet mentioned, kind of comes together with your own attitudes and beliefs, reflecting on those, and having a plan in place and a policy in your agency can also help to support you when it comes to screening moms, having an algorithm at hand, being prepared to intervene regardless of what results you will discover. Perhaps having a mental health pathway or quick access to mental health services, especially if we identify mom is experiencing a mental health crisis. These are all tools that can be at your fingertips to help you in response, especially if screening is something that is new to you. What is your plan as a healthcare provider once you've completed the screen? What is going to be your next steps? That pretty well summarizes 1.2. I'm not sure if there are any comments or questions to be added.
Does anybody have any comments or questions for Megan?
Great job, Megan.
Mm-hmm.
Thank you so much.
Sydney, I hate to do this, but I'm going to have to leave in a few minutes.
Right.
I don't want kind of the rest of our agenda for the day to disappear. So I'm wondering if we can agree to continue with this at our April meeting in terms of moving on to the recommendations, the second set of recommendations. People can maybe read the document in advance of that. It might be wise to, if we all go away and think a little more about screening and how we could do it in our settings, and if we have any questions, bring that back for their next meeting. That could be an agenda item. So that's just, I'm going to sign off in a few minutes. I too would really like it if our meetings could be slightly earlier, and I know we, those of us who have been in the community of practice till now, we did a doodle poll, and the overwhelming majority of people wanted to meet at 11, but I'm not going to be able to do that moving forward. So I could do meeting at 10, or I could do like meeting at 10:30 for half an hour, but I can't do another meeting at 11. So just consider that.
Yeah, absolutely. Absolutely, we can look at that again. So just so that I'm making sure that I'm hearing that there's more of this document that we can continue reviewing together at the next gathering. Is that what you're proposing? And that we encourage people to do a bit of a reading of it, and just come prepared to have a fulsome discussion.
Is that okay with everybody?
That's fine with me.
Yeah, I think that's what kind of makes sense, because we want to keep these meetings to an hour.
Yeah. Oh, absolutely.
Yeah. And maybe I'm sorry. The other thing is, I'd really like to hear from Ellen. I know she's been typing some comments in. And yeah, Ellen, if you can figure out the microphone piece, you have a lot of wisdom in this area too. So it'd be great to hear from you when you're discussing some of the recommendations.
Right. So we'll either stick to our usual telephone approach next time, or if Ellen can get on a microphone, that would be great. Moving completely to Zoom has allowed us to do a recording of this that we could share as a resource to the rest of the network. So is there particular areas that, again, we're going to have somebody lead us through next time, or is it going to be a general discussion?
This is Janet. I'm just going to check my notes from way back when. We talked about Ellen going through practice recommendations 2.1 to 2.5.
Right.
And then me going through 2.6 to 2.10.
Okay.
And then Megan was going to do practice recommendations 3 and 4. We might only get through all the 2s because there's so many. But yeah, that was kind of the plan, unless somebody else wants to step up and do it.
Okay. All right, that sounds really great. So I'll connect with Ellen around technology, and I'll send out a reminder. So I'm going to stop share right now, and I'm going to stop recording since we've wrapped up the that part of the. Okay.